Yeah, visible, sir. Visible, sir.
Good, good, good. So I just went through one slide here. It is about my objectives and then the slide. So it is very important to see this slide and understand this, because in the first half of this slide here, it shows the disease, healthy alveolus, and in the second half, the um, diseased alveolus. So in the healthy alveolus, the lumen is filled with air. One or two alveolar macrophages, type 2 surfactant cells, very important for the circulation of surfactant in the interior to avoid collapse of the alveolus, followed by the interstitial space. See how thin is the interstitial space here, and then the alveolus, surrounding alveolus here. So red cells are happily circulating inside, and the gas exchange is happy to take place here. Let us come to the diseased alveolus. So once the pneumonia process sets in, pulmonary edema, fluid into the lung, cytokine infiltration, leukocytes, and various macrophages will get activated. They will release tumor necrosis factor and other kinds of cytokines into that. Hyaline membrane formation will take place inside, making the gas exchange very difficult. Sometimes the necrotic cells also tend to develop in the apoptosis process. It starts happening within the alveolar lining here, and the widening of the interstitial space between alveolar uh, lining and capillary lining. In the capillaries, RBCs are circulating, but still neutrophils have popped in with the widening of the spaces. So there is increasing fluid loss, capillary leak is taking place here, widening of the interstitium, and macrophages, neutrophils also present in the interstitium. So gas exchange becomes extremely difficult in view of this widening of the space, hyaline membrane formation, capillary leak, and not many uh, RBC circulating over here. So, is it a wonder to think about it for a diseased lung to heal from this stage back onto normal healthy lung with the alveolus seen on the other side? How long it takes for this process? So, it is not at all surprising to me. The only reason why we survive when we are affected with the pneumonia is it is a heterogeneous process. Not all the alveoli within the body, within the lungs are diseased like this. If 20% of the alveoli are diseased like this, probably we can cope with 80% of the healthy alveoli and some in the intermediary range without any need for oxygen. When the more 40% of the alveoli are getting affected, you will be needing some oxygen help and positive pressure support, etc. When it comes to 80% or so, probably none of the other mechanisms will work, and you have to rely upon a bypass technology such as ECMO, which completely takes over the function of lung and um, provides you with oxygenated air, oxygenated blood, sorry. So the VV ECMO, it is very important to understand is it is a supportive mechanism and it is not a cure. So we are providing oxygenated blood to the patient till the underlying septic process, underlying pneumonia heals. So it is only a curative, it is a supportive mechanism and not a curative mechanism. Nature is great, it heals most of the things given time and do no harm and support during this repair process happening. So we take blood from the biggest reservoir wherever you can collect the blood from. In this case, inferior vena cava and superior vena cava, and you after the blood is driven by the pump to the oxygenator, it gets purified, and the red oxygenated blood is returning back to the right atrium, from which it will circulate to the rest of the body via pulmonary circulation. So this is the underlying principle. This is a circuit diagram in a neonate. There is a WM cannula here. You can see the venous side represented in blue color, and these um, corresponding tributaries coming off from the circuit are called pigtails. There is a language in ECMO that we use. These connections are called pigtails. So the blue blood or deoxygenated blood is circulating here, is drawn up at the speed you want, at the negative pressure, desired negative pressure you want. But most importantly, you are measuring the flow here, how much flow you want. As they are proportionate, machine will regulate that. uh, so the pre-oxygenated blood is going to the membrane oxygenator, uh, and from here, um, oxygen is getting circulated to the membrane oxygenator, and after the process of gas exchange, oxygenated blood is returning to the body at right temperature. So this is all this cartoon is indicating. The first case of ECMO, as we learned, was in 1975, Esperanza. It has remained as a hope for the ECMO community. I like this slide very much. This is from European Society of Cardiology. The entire field of ECMO is just this one, mostly this one. You do ECMO for two reasons: for hypoxia or hypercarbia. Blood is collected from the venous chambers, anticoagulated, goes through membrane oxygenator, and goes either to the lungs for venous ECMO, or to the aorta for arterial ECMO. So, and the gas is circulating here. That is the difference between. This is the slide telling you entire thing about ECMO. Further details about modifications, extra cannulations, hybrid ECMOs, etc. we are going to learn in future. But this is the basic physiology and how ECMO works. And dark blood is removed from the inferior vena cava SVC, whichever is the biggest reservoir of blood. From there, you need to collect the blood, and the bright blood returns to the right atrium, mixes with the rest of the venous blood, and goes to the right ventricle. So, the carbon dioxide oxygen content in the arterial blood is a mixture of the returning circuit blood when blood is in the right atrium, venous blood that bypasses the circuit, and any gas exchange occurring in the recovering lungs. So it is a mixture of all these different locations from which blood is being corrected. So though the arterial blood or the oxygenated blood is returning to the right atrium, it is a content of the return circuit blood, which is sort of 98%, 100% oxygen, but it will be getting mixed up with the venous blood coming from the that bypasses the circuit, and the coronary circulation blood, which is adding up here. Any gas exchange happening within the recovering lungs, so it will be mixed up. The percentage comes down after that. It doesn't matter. VV ECMO physiology wise, CO2 clearance is relatively easy. Oxygen delivery is the key and can be troublesome. The goal diversion of venous blood is 75% or greater, with a goal of 50 cc per kilo in adults. It needs a large drainage cannula, and if the lungs are non-functional, SATs will be around 80s. Still, if the lactate as a tissue perfusion marker is acceptable, these numbers are also are acceptable. So that is not like a failure of ECMO. The patient can still survive despite the saturation being in 80s in venous ECMO, provided the lactate is normal. Monitor the surrogates of tissue hypoxia, as I said, like lactate. And this is one of the examples of how a WMN cannula has to be placed and how the blood will circulate. You can see to the left side of the slide, placement of the WMN cannula through the internal jugular vein. Here the different openings. The first opening is at the level of superior vena cava, joining right atrium, and the second one is the tip is in the inferior vena cava, joining the right atrium as well here. So the blood coming from the upper part of the body as well as the lower part of the body will be sucked in by these two holes from there into the venous circulation. This blood goes through the membrane oxygenator, and the oxygenated blood will return back to the right atrium here, um, and it will go to the natural pathway to the right ventricle through tricuspid valve, and from there to the pulmonary circulation. So to the right side, it is very clearly seen with the bigger holes. So the blood coming from the SVC is sucked up, as well as the blood coming from the IVC is sucked up. So we will be collecting maximum amount of blood from the upper extremity as well as lower extremity. The indications are more or less common in whatever age group they are, neonates, pediatrics, or adults. It has to be a reversible respiratory condition where the heart is not under stress. Maximal uh, maximal influence will be by uh, by removing the carbon dioxide and adding oxygen through that, but the process should be reversible. If it is not reversible, the only reason if for putting the patients on ECMO is if you have plans for taking them through the um, heart transplantation at a later date, then you can continue them on ECMO, because this is not a black and white scenario all the time. Sometimes it could be gray as well. So initially it may look like it is a reversible respiratory condition, that's why you are putting a patient on ECMO. Later on, it might prove that this is irreversible condition. Cardiopulmonary interactions always have to be thought about, because lungs don't work by themselves and heart doesn't work by itself. So it's always blood circulating between the heart and lungs like that. So the cardiopulmonary interactions have to be considered. Failure of maximal conventional ventilation and initiation at the right time without undue delay as far as possible. The pathology should be reversible and there should be no contraindications for anticoagulation. As the blood is moving towards cannulae, it tends to clot. So to avoid that clotting, heparin is the commonest agent that is being used, though there are other agents available as well. We will come to know in the next few topics. Common adult and pediatric indications are pneumonias, ARDS, acute respiratory, reversible respiratory failure, status asthmaticus, a very good indication when none of the bronchodilatory therapy helps in getting rid of the carbon dioxide, because carbon dioxide is a major killer in patients of severe status asthmaticus, and it doesn't give you a lot of time either. So in those cases, if these very resistant cases of status asthmaticus with high carbon dioxide have got approach to ECMO, they can survive. And it is a beautiful technology because they don't need ECMO for long period of time, just for a few days, and then they will be off on their own. Pulmonary hemorrhage, though heparinization is a contraindication when there is bleeding going on, but still ECMO is the methodology of choice for treating persisting pulmonary hemorrhage, which is which is not amenable to treatment on the conventional ventilation. Perioperative support for airway surgery, we briefly touched upon during Dipanjan's talk also. Severe air leak and burns, severe burns, respiratory burns to the lungs. These are the indications for going on to ECMO. Basically, when gas exchange becomes very difficult after maximal conventional ventilation, that is a time to consider going on to ECMO. In the neonatal period, these are only specific for the neonates: meconium aspiration syndrome, PPHN, congenital diaphragmatic hernia, severe sepsis or pneumonia, severe RDS which doesn't respond to surfactant therapy alone, and air leak syndromes where the lungs are battered. So these are the common neonatal conditions for ECMO. Which are the conditions which do not respond for ECMO at all? These are the irreversible conditions. A damage which is not rapidly reversible, bronchopulmonary dysplasia. Nowadays, it is becoming a relative contraindication, BPD. Congenital pulmonary malformations, because the lungs are the problem there and the lungs have to be changed. Lymphangiectasia, congenital surfactant deficiencies, a genetic defect, and alveolo-capillary dysplasia, again another genetic defect. Alveolo-capillary dysplasia means in the lung, alveoli are at one place and capillaries are at a different place. Capillaries do not surround the alveoli homogeneously. At some places they do, but at most other places they don't do. So this condition is called alveolo-capillary dysplasia. Neonatal contraindications are age less than 32 weeks or 34 weeks, because the smaller the baby is with respect to the gestational age, intraventricular hemorrhage possibility is high. That is the reason we don't put babies less than 32 weeks on ECMO. Weight of less than 2 kilos, it is a relative contraindication as well. We put up to 1.8, 1.7 kilos also, we put on ECMO, but they are mature babies, small per gestational age babies, and not the premature babies. Ventilation of more than 10 days. It is a high pressure ventilation. It is not the total duration of ventilation. When the patients are on high pressure, high FiO2 oxygenation for more than 10 days, it becomes contraindication, because fibrosis will already set in by that time. So there is no point in putting them on ECMO. Intracranial bleeding of more than grade 2 severity, irreversible disease, disease with poor outcome, and limited heparinization, where heparinization is not possible. In those cases, these are contraindications for going on to ECMO. ECMO is also very helpful in our obstetric population for pregnant women in case of severe ARDS, H1N1. In those cases, it was tried and felt to be very, very helpful when mortality is certain in severe preeclampsia, amniotic fluid embolism, massive obstetric hemorrhage, and severe sepsis. These are the 5 conditions in obstetrics for which ECMO would be useful. The modes of ECMO are VV, which I am covering now. The methodology is by draining blood from the
क्या हो रहा है?
atrium, via femoral,
गए उसके मम्मी पापा?
by jugular or femoral vein, and returning it through the oxygen through the same cannula into the right atrium, or through a second cannula into the femoral or jugular vein. So these 2 methods can be tried in veno-venous. Very briefly about VA ECMO, because in neonates as well as in children below 2 years of age group, even though it is a respiratory condition, still one has to put the patients on veno-arterial ECMO. The cannulation would be for draining the blood, it is from the right atrium via jugular vein, uh, and femoral vein only after 2 years of age group, or 10 above 10 kilos of weight. Only then femoral vein has to be accessed, but before that it has to be jugular vein only. Returning it into the aortic arch via carotid or femoral artery. Again, carotid artery till 2 years of age or up to below 10 kilos, and above 10 kilos or above 2 years, you can try femoral artery. Features of venous ECMO are percutaneous cannulation is possible, carotid artery remains intact. It only provides minor cardiac support, because myocardium could be depressed secondary to hypoxia. Once oxygen is provided, heart will recover once again. So even though there is a mild need for inotropes also, once the patient goes on to ECMO and gets oxygenated blood, myocardium starts recovering and starts pumping normally. So your inotropic requirement will go down and you can stop as well. Coronary artery blood is oxygenated here, monitoring via arterial saturations and suitable for respiratory disease only, not for cardiac support. ECMO referral criteria are high peak inspiratory pressure, usually around 30 or 35 peak inspiratory pressure, high PEEP more than 10, high FiO2 close to 90%, 100%, dependent on the disease, speed of onset and stage. But at the end of the day, it is an individual assessment which remains a priority, like which patients will get benefit of ECMO. Contraindications are ventilation of more high pressure ventilation of more than 7 to 10 days, intraventricular hemorrhage, or in neonates more than grade 2 IVH, intracerebral hemorrhage, uh, irreversible disease, disease with poor outcome, and a limited heparinization. These are the contraindications. Some of the X-rays very quickly. This is a WM cannula which is placed in the right atrium here. Uh, Similar picture. And in the neonatal population, um, oxygenation index is very useful for identifying the candidates who will benefit from ECMO. Oxygenation index is MAP times FiO2 divided by PaO2 in millimeters of mercury. Mean arterial pressure times FiO2. This is the uh, uh, number to be divided by PaO2 in millimeters of mercury. So if it is more than 40 for more than 4 hours, it correlates with 80% mortality. In adolescent as well as in adult population, we go by Murray score uh, to decide about qualifying criteria for ECMO. Murray score has got 4 parameters. They are scored on a scale of 0 to 4, like PaO2 by FiO2, chest X-ray, infiltration, how many quadrants are infiltrated on the chest X-ray, PEEP less than 5 up to more than 15, and the compliance. So once you give a score in 4 different arenas, you take a total of that score and divide it by 4, and if it is more than 3 at the total score, it becomes an indication for going on to ECMO. Other ways of measuring failure are also there, such as uh, PaO2 of less than 50 millimeters of mercury for 4 hours or more, cardiovascular instability and failure to improve. These are the other indications for going on to ECMO. But ultimately, the physician's viewpoint, which will be more valuable. Cannulation, I will consider VV mainly. Appropriate size WMN cannula if it is available. If not, single lumen cannula could be used separately. The tip of the cannula in the lower third of the right atrium, if it is a WMN cannula, it goes into the inferior vena cava and stays, upper openings remain in the superior vena cava. In the arterial side holes, they face tricuspid wall, and the oxygenated blood will go through the right atrium into the right ventricle. In hybrid cannulation, you will be needing more blood. This is when the amount of blood going through venous circulation is not sufficient to provide enough oxygenation to the patient, and you need more blood. Then you resort to hybrid cannulation. Just as a point of note, in veno arterial cannula, in the tip lies at the common carotid artery and of the common carotid artery orifice, the orifice of the innominate artery. So this is only for children less than 2 years, less than 2 years of age group, or less than 10 kilos of body weight. So some of the photographs of cannula, a WMN cannula being seen here with side holes and 2 additional
क्या
cannula.
क्या कर रहे हो? कितनी बार आओगे?
Akash, may I request you to mute, please?
Sorry, sir.
And you can see crescent cannula, which is a later modification of Avalon cannula. So once it is in position, as we saw earlier, the end of superior vena cava will suck blood coming from the upper part of the body The cannula tip in to be IVC will suck blood coming from the inferior vena cava, and the oxygenated blood is released into the right atrium to go through the natural circulation via right ventricle. A double lumen cannula in situ here. We tend to place it under fluoroscopy guidance in a baby. Again, a single double lumen cannula here, and this is an X-ray of multiple pneumothorax baby with multiple pneumothoraces. Uh, that is an indication as the lungs are already battered. Secondary to the barotrauma, they are going on to ECMO here. This is a picture of veno-arterial cannula here. The venous cannula to the right side, and arterial cannula here as well. So in life, it looks like it, a baby with the double lumen cannula in situ. Here is a, you can see two different cannulae. In the bottom one is the venous cannula going into the internal jugular vein here, and the top one is the arterial cannula for reinfusing oxygenated blood back to the baby here. Similarly, in adults, femoral cannula. As I mentioned earlier, minimal inotropic therapy secondary to myocardial depression could be reversed by providing oxygenated blood to the patient. So, if a patient is on minimal inotropic support, it is not a contraindication for going on to venous ECMO. Major inotropic support, VA ECMO is needed, but minor inotropic support, VV ECMO can be considered. The advantages of VV are it causes pulmonary vasodilatation secondary to provision of oxygenated blood back, and provides a good myocardial oxygenation too, maintains pulmonary blood flow, and it is minimally invasive. But the disadvantages are it causes slower stabilization, no circulatory support, and it can cause recirculation. We will touch upon recirculation in the next two slides. Rescue ventilation is a must when you put a patient on ECMO, because the main reason for going on to ECMO is because the lungs are battered on high ventilatory settings, subjected to barotrauma and valute trauma. So you're going on to ECMO. There is no point in continuing on these high ventilator settings even after going on to ECMO. So that is the reason you have to give rest to the lungs, bring them down to the minimal requirements here, or sometimes they can be extubated as well for going for reintubation at a later date. Generally, we tend to choose these criteria: peak inspiratory pressure of 20 and PEEP of 10. That is, a pressure support of 10 on the top of PEEP will equal to peak inspiratory pressure of 20, rate of 10, inspiratory time of 1 second, and FiO2 of air to 30% oxygen. The management is heparinization is crucial. We tend to keep the heparinization low in venous ECMO compared to VA ECMO. In VV ECMO, ACTs should be between 160 to 180. Chest physiotherapy is a must after a brief period of rest to the lungs, prone position to be adopted, fluid balance, dry body weight if possible, rest ventilatory settings. Awake ECMO is possible in selective cases, early enteral nutrition, and infection control. These are the most important ECMO management steps. I know about the recent trial in adults which shows prone position is not very helpful, but it is still debated at this point of time. We were in a meeting very recently with Dr. Gattinoni, and he used to say like this is a very heterogeneous population. You cannot compare these human subjects who will benefit from from prone position to who doesn't develop get better with prone position. So it is still debatable. Complications of VV ECMO are patient related and circuit related complications. I'll touch upon very briefly as my time is uh, coming to closer and closer. bleeding and clotting, hemolysis, renal failure, hypertension, cardiac dysfunction, arrhythmias, neurological complications, etc. So these are all the complications to be monitored within patients on ECMO. Circuit-related complications are failure of the equipment such as oxygenator failure, pump failure, air embolism, heat exchanger fault, clots in the circuit, and cracked connectors. An important subject of recirculation. Recirculation means literally the oxygenated blood which came back to the right atrium is again going through the return cannula or through the as a pre-oxygenator blood without getting circulated to the blood, that is recirculation. So it is self-explanatory. We are infusing blood into the right atrium with our impression that blood will go to the pulmonary circulation. But if the cannula tips are nearer due to excess suction pressure, uh, the blood whichever is coming from the return cannula will be immediately sucked by the returning cannula to the oxygenator. So with that, efficiency will go down. Patient will not be getting oxygenated blood and they will get cyanosed, followed by all side effects of tissue hypoxia. You can also assess the percentage of recirculation. It is very difficult to run VV ECMO without recirculation. With a WMN cannula, they attribute to it around 2% of recirculation, 2 to 4% of recirculation. But otherwise, if there are single cannula, depending on the distance between the drainage cannula to the returning cannula, uh, recirculation fraction might change. It is calculated as a saturation of oxygen in the pre-oxygenated blood or pre-membrane gas minus SvO2, which is the venous blood saturation, divided by post-membrane gas saturation minus venous saturation here multiplied by 100. So that gives percentage of the blood in recirculation. So when recirculation starts, one of the very important tasks for us to recognize this, you will lose this identification of the two different colors. Here you can see the dark blood or the desoxygenated blood as a dark in color and the oxygenated blood as red in color. So when it is when it is uh, a high proportion of recirculated blood going back to the circuit, you will see both the cannulae here with red blood, because the red blood is coming to the right atrium, and again similarly the red blood is getting sucked into the drainage cannula. So in that case you will lose this color difference. That is very important to keep an eye on this. And here this process is exemplifying. Ideally, if the distance between the two cannulae is around 15 centimeters in adults, that is a desired distance that will minimize recirculation. So the blood is ejected from the returning cannula going through the right ventricle, and part of it is getting sucked in here, not a lot, part of it. But once the distance between returning cannula and drainage cannula starts coming down, more and more blood, which is directly ejected from the returning cannula, is sucked um, by the drainage cannula. So the distance between the tips of drainage cannula and returning cannula are very important. It is possible when the patients are being moved and subject to um, physiotherapy, walking and all these exercises through, then it is likely that the cannula can migrate, can go in, can go out as well. But this happens when it goes in. The first noted indication of recirculation is progressively decreasing pulse ox on the patient, usually below 86%. Confirmatory sign is increasing pre-oxygenation because you are getting oxygenated blood back to the oxygenator. So it looks red. And losing this uh, color difference between the venous blood as well as the arterial blood on that. What causes recirculation is usually the cannula migration, excessive flow rates, or abnormal flow differentials causing increasing resistance within the right atrium. So the measures are first evaluate what is the cause for this and do a chest X-ray. You can see the tips of the cannula where they are, or you can also with the fluoroscopy or esophageal echo, you can find out where the cannula tips are and adjust them accordingly. For two cannula setups, increase the distance between the inflow and outflow to optimal distance of around 15 centimeters in adults. So you are on ECMO with the principles we discussed earlier. You are continuing on ECMO, and the patient is improving. Chest X-ray is getting better. You think about weaning the ECMO, like you want to come off the ECMO. See if the patient can tolerate coming off ECMO or not. For that, different techniques are available. Different protocols are adopted by different units. But one of the popular methodology is this: first, decrease the ECMO flow in an adult to 3 to 3.5 liters, say, to that you come down to that ECMO flow. Then you reduce the FiO2, otherwise we call it as a sweep gas also, by 5% every 1 to 2 hourly, decrease up to 50%. And you can subject the patient to oxygen challenge test, see if it is positive. If we ventilate the patient and patient is the blood gas is good, saturations are good, etc., then moderate ventilator settings further you can come down on. Decrease the sweep gas at this time, adjust as for the blood gas, and stop ECMO completely once the patient has good blood gas and good, reasonably good functioning lungs. So, trial off and decannulation is when the blood gases, chest X-ray improve, flow and oxygenation, FiO2 can be weaned. Ventilatable patient on moderate settings, then you remove cannulae, uh, prevent bleeding. Need for second ECMO or re-ECMO is sometimes there. In my experience, I have seen it to 5% of the cases might be needing up to re-ECMO. So the follow-up is very important for venous ECMO. Respiratory wise, lung function follow-up, treating infection-related issues, psychological well-being of the patient as they were on multiple sedative agents for prolonged period of time, cardiac evaluation, physical therapy rehabilitation, neurological, sensory neural hearing loss, quality of life issues. They have been documented in patients with who have been on VV ECMO. So in the follow-up clinic, all these factors should be addressed. In 1999, that was nearly 24 years ago, I was decannulating a baby at that time. And this is how uh, the wound looks like, and it will heal pretty quick. How long will it take for recovery of the lungs means $1 million question. As I said, it can take any longer. If provision is available for you to resources are available for you to continue in ECMO, please do. In the adult world, they came up with the paracorporeal lung assisted devices, uh, like this man and this child on ECMO, as well as with this paracorporeal lung assist, just with oxygen provision, they can walk around here till either the lung heals or till bypass, and then either heart lung or lung transplant becomes available. Lung transplant following COVID era is talked about as a very important technology. Pediatric lung transplant wise, they have reasonably good results. You can see the survival rates here as well. They are good at to 65 to 70% survival rate at 1 year, and to 50% survival rate at 5 years. In the adult, 3-year survival rate of 65% and 1-year survival rate of 85%. This is from centers in USA. So, uh, following COVID, uh, we are becoming more and more aware of lung transplantation for patients in this group. ECMO is used for prolonging life but not death. We presume that the patient's pathology is reversible, put them on ECMO, but unfortunately, if it progresses to reversible pathology, we should resit with parents or family and decide if it is better to stop ECMO at that time. Someone with severe intracerebral hemorrhage, for example. So we all talk about this as ECMO is used for prolonging life, but not for prolonging death. So take home message from my presentation is we discussed about indications and contraindications for venous ECMO, the selection criteria, Murray score and oxygenation index, initiation and management of VV ECMO, recirculation, weaning and decannulation process, prolonged ECMO, management strategies, how they are doing in the Western world, and further advances. These things we talked about. If there are any questions, I'm very happy to answer.